Okay, welcome back to FTAG Journal. This is F555, the right to choose and be informed of your attending physician. So, table of contents, it's always the same. It's overview, citation history, interpretive guidelines. Then we'll go through the surveyors, what they're going to ask, what they're going to look for, and the actual citations, and then a brief summary. So, the overview, this is a preference or choice-based FTAG. Really all it's about is the resident's right to choose their physician. If the physician that they choose, say it's a doctor that doesn't work in long-term care, but they've been their lifelong doctor, if they don't meet the obligations that are required by CMS, facility policies, interpretive guidelines, everything that you can imagine, if they don't meet the obligations, then what is the process to work through that, and what the notification requirements are if the chosen physician does not meet the obligations. So citation history. This is not a frequently cited FTAG. Its rank is 155. In 2018, there was only 22 cited. And in 2019, it was even less. There was only 8 cited. And as we go through the actual citations, I'll kind of point out pretty much how the few citations that were cited, how they came about. And 72.7% came from annual survey. These are not very high on the scope and severity level in terms of citations. There's only 2 E's and the remaining are D's or less. As far as distribution, the only thing I would point out is maybe Idaho for only having 80 some facilities. They got 4 citations. That sticks out at me. Other than that, nothing really stands out. Least cited states, there was only 22 in 2018, which these percentages are based on. 41 states with no F555, Ohio, New York, North Carolina, California, all less than 0.02%. Most cited, it's going to be Montana, Maryland, Washington, Massachusetts, and Pennsylvania. And even the most cited state is at 0.6, at least in the top 5. And then the least cited, California at 0.2, so not a whole lot of difference between the least and most. So the interpretive guidelines. Resident has the right to choose their own physician. However, if the physician does not meet the obligations and the requirements, such as not having a license to practice, not doing their mandated visits, not responding timely to calls from staff, there's numerous other things, well then the facility may seek alternate physician assistance. A couple things. The resident cannot be required to choose a physician. I have no understanding why that would be an issue, but they put that in the interpretive guidelines that the resident cannot be required to choose a physician. On the other side of the coin, the physician chosen by the resident is not obligated to provide services to the resident. And this has come up a couple times, and I've actually had to transfer a resident out. They were incredibly problematic resident, was never happy, and the medical director just said, I refuse to provide services to this resident anymore, so we had to find alternate placement. We ended up discharging her to a adult family home, which was a more appropriate setting for her. So the facility has a responsibility that each resident and responsible party is informed of the name of their physician. So that's not only the medical director, but also if they have a nurse practitioner or anybody that has a specific role, maybe physical therapist, need to know their name, what their specialty is. So if it's a nephrologist or an orthopedist, whatever their dentist, whatever their specialty is, the resident and responsible party need to be informed of what their specialty is. They also need to be informed of the physician contact information and the method. Nowadays, any contact information includes both mailing address as well as an email address. And if the physician is old school and doesn't have an email address or doesn't do business through email for any resident stuff, then that needs to be documented and noted so you don't get a citation. If the physician that the resident chooses does not meet the obligations required by either the facility or CMS, then the facility has a responsibility to discuss alternative physician services with them and the responsible party. If there are other options that the facility can offer, maybe they have a doctor that is willing to come in and provide services for just a couple residents, and the medical director thinks it's a good idea. Maybe the outside doctor has a specialty with pain management or something like that. It's the facility's responsibility to do their best to honor the residents' preferences if the alternate physician does meet the requirements. There's no point in going from a physician that doesn't meet the requirements to another one that doesn't meet the requirements. So what are the surveyors going to look for? What are they going to have to determine? Well, the first thing they're going to determine is that if the residents and responsible parties were informed of their right to choose a physician, and also if they were supported in that right to choose their physician. The surveyors are going to determine if the resident and responsible party know how to contact their physician or their primary care physician. If the primary physician or their choice did not work out, then the surveyors are going to determine if there were any options offered or sought out for physician assistance. And finally, they're going to find out exactly what they did. I mean, those last two bullet points are kind of along the same lines. Were there any other options for physicians? And if so, did the facility work with the resident and responsible party to find an alternative? Which that can be tricky, especially if you're out in a rural area and you're a small facility, or maybe you're 100 beds, a little bit bigger, at least on the West Coast. 100 beds isn't considered small. I know in Ohio, and some of those bigger states, they got 300-400 bed facilities, but not too many of those out on the West Coast. So it can be difficult to find physicians out in these rural areas. A lot of times they're partially retired physicians that just do the geriatric care, and sometimes when they retire, it's incredibly difficult to find a new medical director. So moving on to actual citations. So we got a B, a C, and a bunch of D's. So the first one, responsible party complained of not being able to contact the physician without going through the facility staff. C level, resident only offered one physician, so I don't says there to choose from, but if you're only offered one, I mean, that's not much of a choice. So resident complained that the physician had poor bedside manner and was argumentative. Complained to the facility, and the facility had no documented evidence that they tried to find an alternative physician for the resident who did not like their doctor. Facility was unable to find a new physician for on-site visits. Again, that's kind of the example I gave with some of these rural facilities that have a partially retired physician, and then when they fully retire, it can be difficult because oftentimes some of these kind of in the middle of the country, Oklahoma, Kansas, some places like that, the next closest town may be 50 or 60 miles away. So it can be rather difficult. Let's see. A resident requested a new physician after the resident had been in the facility for 5 days and still had not seen the physician. I'm not quite sure. I mean, most of the facilities I've been at, the physician would come in once, maybe twice a week. Lately, in the last couple of years, I've been seeing a much more involved physicians group that may have one or two physicians that come in, 2-3 times a week, and some nurse practitioners that are even there 4 or 5 days a week. So that does appear to be trending in that direction where they more have a constant presence. And I can imagine if it's some of those bigger facilities like 300-400 bed facilities, you would have a medical director or physician's nurse practitioner that's there every day. The facility got a new medical director, and the resident requested to stay with the former medical director as their physician, and they were unable to. The citation did not go into the specifics of why they were unable to, so I was kind of curious about that. Resident requested a new physician. Physician continued to write orders for the resident, and there was no documented evidence that they were working on finding an alternative physician for the resident who wanted one. Next page. Daughter requested a physician change, and the facility had no documented evidence that they did anything for 6 weeks. And at the 6-week point, the daughter complained to the state. The state came in and wrote a citation because they had no documented evidence of any attempt. Resident requested a new physician, and the current medical director refused to allow any other physician to treat. On that one, the facility's got to step in. The administrative director of nursing has to step in and say, hey, look, if they want a new physician, we got to go ahead and look for one. So it's not the medical director's call. If the resident doesn't want that specific physician, my doctor, my choice. So resident requested a new physician due to the physician denying the resident to increase his narcotics. The facility had no documented evidence that they assisted the resident in finding a new physician. This is actually common, especially with residents that may have some addiction issues. They always want more narcotics. I know there's a big push to limit the amount of narcotics that are prescribed, so this can be a little bit of a tricky issue. Resident wanted to see their primary care physician, and there was no attempt by the facility to set up an appointment with the primary care physician. Resident was told that they had to choose the facility's medical director or they'll have to be discharged. Physician contact information given to the resident and or responsible party was not correct. The resident requested a Spanish-speaking physician, and the facility had no documented evidence that they attempted to find a Spanish-speaking MD. Had they documented those attempts and made some calls, they very well likely could have avoided getting that citation. Okay, just a couple things for the summary. Finding a good medical director can be problematic for some rural facilities. What I've seen is that a lot of times you'll have a physician and who's a little bit up there in age that is partially retired, and at some point they do fully retire. And there's not a whole lot of other physicians around. You may be a ways away from a hospital, maybe a half hour or something like that. And if you're a bigger facility, it can be a little bit difficult to get a medical director. So just one thing I've noticed. The other thing is that the value of a good medical director really can't be overstated. I mean, it is incredibly helpful, incredibly encouraging. Makes staff. If you got a medical director that your nurses don't mind calling, and he's just got an excellent rapport, and the physician doesn't mind answering calls late at night and stuff like that. If they're patient and they're just generally have a calming personality, I mean, that is incredibly valuable. If you got one of those, consider yourself lucky. There is starting to emerge a lot of these geriatric physician groups. They have a lot of doctors that do have a lot of experience in caring for the elderly and this sort of demographic of the population, and they seem to be doing a very good job from the few that I've worked with. So that is a sort of a hopeful emergence.